Hello, everyone, and welcome to the Infection Prevention and Transition of Care podcast series, episode 8. Today, we're going to talk about PD core interventions for infection prevention, and I'm joined by Dr. Jeff Perl as our special guest. Dr. Perl did his postgraduate training at University of Toronto, both in internal medicine and nephrology. He completed his Master's of Science in Clinical Epidemiology from Harvard School of Public Health. He's currently a staff nephrologist at St. Michael's Hospital in Toronto, where he's a professor of medicine at University of Toronto. In 2016, he was awarded the John Maher Young Investigator Award by International Society of Peritoneal Dialysis. His primary research interests and clinical practice focus is on improving the survival and quality of patients on peritoneal dialysis. He's currently the editor-in-chief of Peritoneal Dialysis International, and he also chairs the Home Dialysis Steering Subcommittee under ASN's Excellent Inpatient Care Initiative. Thank you so much for joining us today, Dr. Paul.
Oh, it's a real pleasure to be here.
Oh, likewise. And your group in the ASN's Excellence in Patient Care Initiative has developed these core PD interventions to improve evidence, practices, and outcomes in PD. So, congratulations on that publication. And what prompted your group to develop these core interventions to promote PD?
Thanks, Tushar. Under the Excellence in Patient Care umbrella, we've worked really closely with our partners at the CDC with a common and shared goal to try to reduce infections in dialysis. As many people are aware, we did the interventions for prevention of bloodstream infections in hemodialysis, and a natural extension of that work as we see the increasing use of home dialysis and the benefits, to also focus our attention on infection prevention in peritoneal dialysis. So, again, with a really great relationship and foundation with our colleagues in the CDC, we set out to try to work together with a group of stakeholders to try to develop core interventions that would be useful to the kidney community to try and prevent PD related infections.
Well, that's wonderful. And which core intervention was most exciting to get buy-in from your group?
Hmm. I think I think that I'd have to say that I think the I would say that people were excited about all of them, and the truth of the matter is that I think everybody comes at it from their own perspective, and we were lucky to have patient on the panel, nurses, allied health, and physicians on the panel. I think what I would have to say probably deviates a little bit from what you would see in sort of clinical practice guidelines is that we wanted these core interventions to be things that a facility could initiate and a facility could improve upon. And I'd say we focus a lot in PD on making sure that patients are well trained and that patients know what to do. But do staff know what to do? And do staff know get refreshers? And there's been some studies that, especially from Asia, that have shown that actually patients who are trained by staff with more experience go on to have a higher incidence of peritonitis in one study compared to staff with less experience. And of course, some people have said, oh, that's because the more complicated patients go to the more experienced staff, and maybe that's why. But to me, it's like, let's take a step back and say, hey, a core intervention is not only training the patients, but making sure that we are up to date. We are making sure that our competency is being assessed. So I think that that's, in my mind, maybe not everybody was as excited as me. I tend to be more excited about a lot of things, but I think people were. But I like that it brings something that's on our own education and our own need to develop our skills that also calls that into action, in addition to some of the more traditional things you might see in a core interventions document for prevention of PD-related infections.
No, that's very well said, and you bring up a good point that staff training is of utmost important. Was there a core intervention that was very challenging to get buy-in from your group?
Um, I think that they were definitely tweaked, and and the reason we called this group together is because of their vast expertise and their opinions were really well received. I would say there wasn't one that was controversial or there wasn't one that was difficult. I think we definitely had to tweak all of them. And one one example that I think really resonates with me, where we were challenged, was when and this I think does speak to the way in which we deliver dialysis. A patient gets a peritoneal dialysis catheter, and the first time that a clinic might meet or see a patient as a clinic, as a team, is once the catheter's placed and they come to the clinic. But guess what? PD prevention, infection prevention begins from the time you're talking to the patient and planning for PD. And there's a lot of things that we need to think about even before, unfortunately, that aren't necessarily under the purview of the clinic. So I would say that most challenging was the fact that, a clinic can't go back to when, they didn't necessarily meet the patient to try and do those things and think about those things. But a lot of things at the time of the operation and preoperative antibiotics, the way in which we manage patients around the time of surgery, preparing patients for peritoneal dialysis can also have impacts on downstream infection risks, but it's unfortunately not something that a clinic might necessarily have exposure to.
That is so important. Like, we should be thinking about infection prevention from the get-go in the CKD clinic. And um, you bring up good points about, antibiotics to be given even in the operating table, and ISPD guidelines have nicely outlined the kind of antibiotics and
Right.
prevention strategies
Right.
that
But
should be
what are you going
given.
to do about it when a patient already comes to your clinic and has or hasn't got, it's sort of upstream. We've got to make sure that those things are also thought about upstream. And we definitely acknowledge that. And I think it's still work that we want to continue to do and expand these to make sure that people are aware that that's an issue.
Right. So I guess if you had to choose an acronym for your PD core interventions, which one would you choose and why? That sort of gives us an outline of what kind of interventions you've come up with.
Yeah, I'm not going to lie, audience. Full disclosure here. This was a question that was shared with me before, and because I was so nervous about it, and an on-the-fly acronym isn't exactly up my wheelhouse here. But what we came up with as a group was something called SPIES, Protect PD. So S, surveillance and feedback. P, patient training. I, infection prevention assessment. E, exit site prophylaxis. S, staff training. And P, again, procedural prophylaxis. So I spied on the question, and so the mnemonic is a SPIES here.
Well, spies do protect PD. I love it.
Yeah.
And it's a nice way to start off as to what the core interventions are. And
Yeah.
might I say, you should change your publication and add this acronym to the title if C. Jason would allow that.
Yeah. I don't know. I don't know if they're as excited about it as we are, but yeah. But I guess it's something that people can sort of keep and think about. And I certainly will remember them a lot more having the mnemonic.
Perfect. So, any kind of core intervention or practice that you felt had the strongest evidence, and was which of these core interventions were more opinion based or require more research?
Well, evidence in PD always should be in quotation marks, right? Because unfortunately, even with the ISPD guidelines, if you read them, which I encourage you all to go onto the ISPD website and look at the infection related guidelines, we don't have many grade one recommendations. Randomized control trials in nephrology and in dialysis are far and few between, even farther and fewer when we start to distill down into specific subject areas like infection. So I would say that the greatest level of evidence that we have probably is in the procedural prophylaxis. The use of exit site ointment, antibiotics prior to lower GI procedures and gynecologic procedures, antibiotics for wet contamination events. I think those have a stronger level of evidence, perhaps, than some of the others.
Thanks for that. And since this is an infection prevention podcast, so we'll try to stick to the core interventions around infection prevention. You've already mentioned procedural prophylaxis, but could you run us through some strategies to prevent peritonitis amongst home dialysis on top of procedural prophylaxis?
So again, we alluded to this already. Antibiotics at the time of PD catheter insertion is a grade one recommendation from the ISPD to prevent against the risks of early peritonitis. We have good data that the use of an exit site antimicrobial agent such as gentamicin or mupirocin can reduce the risk of exit site infections. And here, right here in the U.S., the evidence was developed for the perhaps superiority of gentamicin for particular gram-negative and Pseudomonas infections, which I think really is probably the reason why, exit site aminoglycoside is the more common exit site strategy here in the US. When patients go for colonoscopy, there's some evidence, again, evidence in quotation marks, that patients should be dry for the procedure and that peri-procedural prophylaxis can reduce the risk of developing a colonoscopy-related sort of enteric peritonitis. Wet contamination, we know that about 5.6% of wet contamination episodes result in a peritonitis, again from data from Asia, and the use of antibiotics around the time of a wet contamination. And the way I describe a wet contamination is PD should either be in the patient, in the bag, or in the system. And if PD sees fluid, sees the outside world, we call that a wet contamination. So patients should get a dose of a sort of agent to cover for the risk of gram-positive infections, just because of that association between wet contaminations and peritonitis. So those are a few of the procedural prophylaxis. And then if non-procedure, but when our patients are getting antibiotics, there is an increased risk of what's an entity called antibiotic-associated fungal peritonitis because
Hmm.
the bowel flora gets sort of wiped out by antibiotics and there's an overgrowth of yeast. So, the number needed to treat is probably very high because yeast peritonitis is very rare. But when it happens, it's devastating, and the catheter has to come out, and the patient has to be switched to hemodialysis in the majority of cases because it's really hard to treat without removing the catheter and near next to impossible. So, for those reasons, we give our patients antifungals for courses of antibiotic therapy, which continue for a week after. And again, even if we can prevent one fungal peritonitis throughout the year, it's a pretty low risk but important strategy to try and reduce the risk of fungal peritonitis.
Yeah, such a catastrophic complication. You lose the PD catheter too. And
Right.
um, uh,
Yeah, exactly.
I audited all the UVA dialysis peritonitis episodes for the last year in preparation since I was going to meet you anyways. Luckily, no fungal peritonitis, but I hear you. You know, we all give antifungal prophylaxis to our patients thanks to the ISPD guidelines, and we haven't had any, but it's such an important thing that people tend to overlook, and it's part of our quality measure now, thanks to your
So
guidelines.
you are doing that at UVA, giving
Yep.
antifungal? Oh, okay. Great.
Yeah. And what advice would you give peritoneal dialysis patients who have domestic pets?
Yeah, so pets is tough because if sometimes when you look at these textbooks and articles, risk factors for peritonitis, people say pets at home. And when you look at pets, the the real risk here is that a pet will get into the catheter area, will puncture the tubing, or will somehow lick or get into somewhere along the system, and will lead to an oral bug peritonitis from the oral bug of a cat or a dog. And if you've ever had a case of Pasteurella multicida peritonitis or Capnocytophagia, those are the sort of bugs that can get into the system if you've got pets. That's, I think, the real worry. So, some people say, well, people shouldn't have pets if they're going to do PD. And I've always said, if you tell a patient to get rid of a pet to do PD, the patient will get rid of you and not the pet. And so I think that that's an extreme. When we looked at globally the overall risk of peritonitis in the PDOP study, we found that if you owned cats or dogs, you didn't seem to be at increased risk of peritonitis. But for some reason, the people who owned cats and dogs um, seem to have an increased risk of peritonitis. I don't know if it's owning cats and dogs or the type of people that own cats and dogs, and maybe it could be a whole bunch of confounding issues. But I think then what I would say is if you have a pet, we should probably risk manage the situation. So, number one, I think, is that if you're doing an exchange, the pets should be out of the room when you're doing the exchange. The big high risk situation in my mind is people who sleep with their pets, and particularly APD plus a cat. Because you're asleep, you're connected to a cycler. Cats like all the sort of tubing and stuff, and they like to touch and feel warm stuff and bite stuff and see bubbles in the line. So that's a really high risk situation. So ideally, if a pet cannot sleep with the patient, that would be ideal. Now, even still, we can say that people are going to do what people are going to do. And the same thing, could be said about, hemodialysis access and risks with pets. But what I would say is that CAPD, if a patient's doing connections and can be disconnected and somehow use a belt to have their catheter out of the mix, they're not actively connected throughout the night with a cat, probably a lower risk situation. So I tell people that who have cats and who are adamant about sleeping with them, that CAPD, continuous ambulatory, as opposed to being connected to the cycler, where there's lots of tubing out there and warm bags, things like that. Cats can turn that into sort of playground. So I tell people that CAPD might be a better option. Even still, in giving talks around the country, I love the nurses out there are so amazing, and they really do what I think is really great, which is, sometimes we try to fit the patient to the therapy. And here's where they, I think, try to fit the therapy to the patient. So I've heard all sorts of things like putting a laundry basket on the cycler so that the cats can't get into the cycler and using the tubing to go through the laundry basket as an ingenious solution. Pool noodles cut and the tubing going through the pool noodles so that the animals aren't accessing these free lines, all sorts of ideas. But I think there's much more work to be done in innovation to try and reduce the risk of pet contamination of the lines. But that's my pet spiel. Sorry for
No,
the
I
long
love I
answer.
love it. I think we should think of innovation around that because we shouldn't be discouraging our patients who have
No,
pets. I think that's the bottom line, and you're
no,
absolutely right. The pets think of those cyclers as toys, and they love
no.
that warmer.
I'd never get rid of my Pomeranian to do any sort of dialysis.
No, you shouldn't do that. And what about water questions like, swimming pool or seawater or community pool? How do you tackle that?
It's really interesting because we have no consensus and we have no good data on swimming and the risk of developing peritonitis. And so the variation in what programs recommend or suggest around swimming is vast. Um, I'm just going to say that this is where we need a lot more evidence generation. The whole concept of exercise and PD, not lifting because of development of hernias, restricting certain sports, restricting certain swimming. The evidence is very poor. And so I would say anything I'm going to say here is not really brought with a high level of evidence. The group that in the PD community is doing a lot of research on these sorts of questions are GREX, the Global Research in Exercise and PD. And if I can hijack your podcast to talk about mine, which is the
Oh,
which
please
is
do.
yes, which is the PD Exchange, which is an ISPD PDI podcast I do with Dr. Nikhil Shah. We interviewed and had a whole discussion with the GREX group, and the issue of swimming has come up in that podcast and all the challenges. So I would say, a few things. We don't want the catheter completely immersed in water like a bath on a regular and routine basis. If some programs use water seal, sort of ostomy type dressings to cover the catheter when patients are engaged in swimming. I tend to be a little bit averse to any hot tub activity with the catheter immersed in a hot tub because of the warm water and the bacterial load. So if someone's going to use a hot tub, a pre-sternal catheter away from the water would be preferable. And you can get catheters that are extended into the pre-sternal area. And then I would say for routine swimming, people have said saltwater pools, private pools that are well maintained with exit site care immediately after, with or without an ostomy dressing to cover the catheter during those activities. But again, there's so much variability, and if anybody out there is looking for a research project or an area of investigation, please think about these areas. And there will be a paper coming out, I think, in C. Jason on
Hmm.
something called sports nephrology, because
Oh, nice.
somebody just emailed me about this very question a couple days ago, who is going to be a sports nephrologist. So this is an evolving area of nephrology. Maybe you can think about for a future podcast.
That sounds exciting. And thanks for telling us about the unanswered questions. And sports or swimming is one of them. And are there any other unanswered questions in infection prevention that could
Oh,
change outcomes?
so many. There's so many unanswered questions. I think that we're really lucky to have colleagues and expertise with infectious disease in our core intervention group. And one of the concerns about antimicrobial prophylaxis, of course, is particularly at the exit site, is are we going to harbor and breed resistance? So I think we're always in pursuit of exit site and strategies that retard against the growth of bacteria and pathogens, but at the same time don't promote antimicrobial resistance. So I think that a real area that we need to focus on is antimicrobial stewardship
Hmm.
and think about future innovation in ways in which we can prevent infections without necessarily having to use the antimicrobial strategies that we do for prophylaxis. And maybe we'll develop some better strategies that are advantageous and don't have that risk of resistance.
Well, thanks for sharing that. And training of patients and staff is also a major focus in preventing PD-related infections. What are your thoughts on, how centers are different in training PD patients? Like, what are the best practices around the duration of training or the methods used?
Yeah, so it's a great question, and I think we'll explore this more on the webinar. We'll have Ana Figueiredo, who is a nurse PhD from Brazil, who has spearheaded the ISPD position statement on patient training. Again, the evidence for how we train and duration and the way in which we train our patients to do, and their care partners to do PD is quite variable. I think that a lot of it remains to be understood. And again, that was going to be, if you'd asked me what else do we need to do research on, it's patient training. We're not going to be
Hmm.
able to open a large database and say, oh, these are the best practices for training. It's really a qualitative type of research that we really need to focus on how to best train patients. Because ultimately, what training is trying to impart knowledge, procedural knowledge on how to do something and also factual knowledge on when to call the nurses, when to be concerned, how to spot a cloudy bag. And, patients, unfortunately, we train at a time in their life where they're undergoing a transition to dialysis. They may be scared, they may be anxious, they may be not feeling well because they're uremic. And on top of it, they have to learn how to do a whole life sustaining therapy. So I think that it's critical. And I think that the connection and the ability to train and impart knowledge is so critical to prevention of infections, particularly those related to the technique like touch contamination and gram positive. But I just don't think we've studied it. And, another branch of EPC has focused on human factors and how we do
Hmm.
things. And I think that there's a whole area of knowledge to be acquired in human factors work in terms of how we can advise our patients and teach our patients. So, and I know that we've done some of that in the excellence in patient care group, but there's certainly a lot of areas to expand upon. I will just point out and shout out to our colleagues from Australia. There's one study coming out called Teach PD, which is half the facilities got a standardized structured curriculum for how to train patients, and the other half of the facilities got the sort of do what you've always done with patient training. And Teach PD will be very informative to the PD community in, again, helping us shape best practices for training patients.
Well, we will be on the lookout for that. Thanks for sharing about Teach PD. Let's shift some gears and talk about your first core intervention, which is talking about reporting dialysis events to track progress and quality metrics in the home dialysis unit. So, Jeff, could you enlighten us what quality metrics you want us to track?
Yeah, so thanks. One of the things that people, if people know me, they know that, in Canada, where I practice, we're not beholden to certain quality metrics to the same degree as in the US. And things like KT over V are reportable. And there's some challenges with KT over V as a quality metric. But it always impresses me that something that I think is really important to patient outcomes and really important to quality is what a clinic's peritonitis rate is. And I think that that's something that we should all be measuring, and we should all be measuring it in the same way, and we should all be reporting it similar to the way we report bloodstream infections. I think the first core intervention suggests that we need to standardize the way in which we report it, and we probably should report it. The details on how, where, when, why, what, sorry, I think still are things that we need to galvanize the PD and kidney communities to help shape and develop. And as we work towards that core intervention realization, I still think that we need to fine tune exactly what we're going to be measuring and how, because there's going to be certain challenges and things that we have to take into account in trying to develop standardized reporting.
Yeah, no, I totally agree with you. Like, we should be doing home dialysis event reporting in National Healthcare Safety Network, which is NHSN. We do it for catheter-related bloodstream infections all the time. And we on our own are tracking our peritonitis event reporting, which will also look at outcomes like who was hospitalized, who had any mortality or modality change, or any adverse outcomes related to it. I think it's so important. Could you enlighten us about the peritonitis rate? I know it is outlined in your guidelines, but some of our audience are nurses and technicians and patients, and um, what is the peritonitis rate? How often it should be monitored by home units or the dialysis organization?
Yeah, I'm not going to have wonderful answers because we're still working on that. The ISPD says that a clinic's peritonitis rate should be no more than zero point 0.4 episodes per patient year. But that's very high. And remember that the ISPD is what I call international. And
Mm,
so when we try to, and that's why I think the whole premise for the core interventions is how do we contextualize the ISPD that's been our main source for guideline-driven infection prevention advice to a US and North American landscape. And I think that's where the core interventions were really helpful. And one of the things I'll say again is that in the US, when we looked at this through our OPUS study, which was an optimizing the prevention of PD-associated peritonitis in the US, which was an AHRQ funded study where we had clinics participate in a peritonitis reporting online module, and the clinics were really so happy that they volunteered their time to contribute. Plus, with the PDOP study, we learned that the US peritonitis rates probably are much lower than that, 0.25 episodes per patient year, with a lot of variation between clinics. So I think we can achieve lower, and I think we should target even lower than the ISPD guidelines because it is possible, and we already on average are below. The problem, though, in the US is not the problem, the challenge is that we treat a lot of patients in very small clinics. And so the peritonitis rates can be quite volatile if you're in a really small clinic. One episode that month, another episode can sort of double your rate. And, so there's a big standard deviation around it. So I think
mhm.
when we're looking at peritonitis rates in small versus large clinics, there's sort of a challenge with the volatility. So I think when we think about benchmarking and reporting a peritonitis rate, for example, at a small clinic, we probably have to use a slightly larger interval because of that instability from month to month. And I think
Mhm.
those are sort of the challenges and kinks that I'm not claiming to be an expert on, but things that people need to think about. The other thing is, give you another example. A patient is your patient at your clinic. They received care at your clinic, then they get admitted to the hospital with, let's say, pneumonia. A week
Mhm.
later, they get peritonitis in the hospital. Is that our peritonitis rate or the fact that they got it in the hospital and did something, was there a breach if we're doing a root cause analysis in the way care in PD was provided in the hospitals, which again is another discussion for another day, and looking at how we manage patients admitted to the hospital and the variability there. So if our whole exercise is to measure something so we can improve it,
Mhm.
all these little kinks need to sort of be worked out as we try to use this information in a meaningful way. So my point is, does that count as the clinic's peritonitis rate? Someone who admitted to the hospital and 2 weeks later gets a peritonitis in the hospital. Those are the kinds of things we kind of need to think about as we work through core number one.
Oh, perfect. And I like how you are suggesting we should have larger intervals, especially if it's a small home dialysis clinic, maybe once a year. I do think we should do a root cause analysis for every peritonitis that
Yeah,
happens because even one episode will teach you a lot about maybe whether we need to retrain the patient or we need to do a home visit and figure out what's wrong in their home environment or
absolutely. Yeah, absolutely.
so would your group collaborate nationally to further propel this core intervention?
I hope so. And if anybody's listening, we're really would welcome collaboration. I think that many people are thinking along the same veins, and there's a lot of activity happening in that area. And I think that we all have the same common goal, so we would be definitely welcome to collaborate.
Right, especially as you know, in United States, uh, dialysis facilities are reimbursed based on quality metrics, and as you pointed out, peritonitis and home dialysis and the outcomes are uh, going to affect the quality metrics, so it should be definitely under consideration.
Yes, agree.
Now, how can facilities adopt, implement, or sustain your PD core interventions? Any other suggestions apart from like having larger intervals and uh, any other tricks of the trade that we should be adopting?
No, I mean, I think that the next step of our group's work is really to give people tools
Hmm.
to be able to go through each of the core interventions in more detail and to talk about how they can be implemented at a clinic level. I think that, you know, it's not infection prevention is not a one solution issue. It's multifaceted. It's multi-pronged. And I think at the center of it all is the patient. And I also want to make sure that throughout all of these implementation procedures and activities that we definitely continue to have our patient engagement and care partner engagement.
Agree, agree. And you are the editor-in-chief of Peritoneal Dialysis International, and from your perspective and experience, what's the one lesson US nephrologists can learn from the global nephrology community?
Hmm. Oh, geez. There's many lessons that I think we can learn, but I think that um, I would say a lesson everybody can learn, and I would say is that the nurses that work and manage and work in PD units have such a vast knowledge and experience, and they're so well connected to their patients and to the therapy and have an understanding of the therapy that I probably will never have. And as a nephrologist doing PD, we're probably also managing CKD and we're managing patients on in-center hemo and maybe we're managing transplant and GN. We're wearing many hats. But I think the PD nurses have really immersed themselves into delivering home dialysis. So I think that the lesson that I want everybody to learn is the importance of teamwork and collaboration and communication with our nurse colleagues, because we're not going to reduce infections without a team approach and without working together as a team, meeting, discussing, having rounds that are multidisciplinary in nature, where everybody sort of can get their views and thoughts across, especially if you're doing peritonitis CQI and root cause analyses. I think I can't underscore the importance of teamwork and working collaboratively and letting everybody's voice and opinion be heard.
Well, that is very well said, Dr. Paul. And I do think I always say the same thing. The nurses are the heart of the program, and
Yes.
a team is stronger than an individual. And I'm so glad that you're sharing the same sentiment there.
Yeah.
And if we had to summarize or one or two takeaways from this podcast, which ones would you want our audience to take away with?
Well, I think one of them, of course, is that infection prevention is a team approach. I think that to prevent something, we have to know how to measure it, and that measurement has to be useful information that we can then use to continually improve. I think that we really need to better understand patient training, and not everything can be answered with big databases and randomized trials. We have to really engage in some more qualitative research. And I think that we just have to take it one step at a time. And ultimately, the whole goal of reducing infections is to make sure that our patients can continue to live independent lives and hopefully bridge many of them to a kidney transplant. And so I would just say small steps, hopefully big gains.
That's very well said. And thank you so much, Jeff, for taking time to teach us about PD core intervention. And everybody who's listening out there, don't forget to tune in to the webinar that is scheduled for June 16th of this year, which will talk more about PD core interventions for infection prevention. Registration will be available on the ASN EPC website. Thanks again for listening to this podcast.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or another qualified healthcare professional. If you have any questions about any medical conditions or before or taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast by the American Society of Nephrology.